Hi everyone, welcome to day 7 of the 10 on 10 series, and we are here discussing 10 questions every single day. Usually the rule is that we discuss 5 clinical questions and 5 image spotters, but today I've got a total of 10 questions where we have clinical, factual, plus the images are already embedded in the questions. So let's get going with the very first question over here, which is fact based and asks you that if you want to sterilize a glass petri dish, which is the technique that you will be using? We prefer to go in for hot air oven, so I will select one of the two hot air ovens over here. The correct temperature of hot air oven is going to be 160 degrees centigrade for 2 hours, and that's the best answer that I'll select. Hot air oven is not done at a 121 degree, that's the temperature of an autoclave. Autoclave is done at 121 degrees, so why didn't I select option A? Because over here the timing was wrong. Autoclave is done at 121 degree for 15 minutes and at a pressure of 15 psi, because autoclave is nothing but a medical version of a pressure cooker. Obviously we don't use it at 134, so all the temperatures over here was wrong. I just know that okay, glass petri dish, hot air oven, the temperature revising once again is 160 degrees centigrade for 2 hours, and that's exactly how a hot air oven looks like. Another question that you can get in the exam is asking you about the control used over here. So we are going to use Bacillus subtilis spores. If this is not written in the question, then they will give you the cousin brother of Bacillus subtilis, which is Bacillus atrophius. And if none of the spores of Bacillus family are given, then the Clostridium tetani spores would be given. And there has been an unfortunate question in the exam earlier where Bacillus subtilis and Clostridium tetani both were there in the options. You had to select the single best answer. So the most common one that is used as a control is Bacillus subtilis. Now let me move forward to question 2, which is a perfect integration of pathology and microbiology. Here we have a 27-year-old male patient, and you will also see in this question how images are embedded out here. This patient is presented with dry cough and fever, and chest x-ray shows bilateral infiltrates. On general physical examination, patient is oriented to time, place and person. Per abdomen examination shows moderate splenomegaly. CBC shows a low HB, so definitely I'm dealing with the case of anemia. And whenever that situation arises, they always give you a peripheral smear. If I just stop the story over here and I ask you what is this peripheral smear showing you, I hope you could identify that these are completely spherical red blood cells and they don't have any pallor. So these are referred to as spherocytes, right? That is point number 1. And I've taught you in so many of the previous lectures that the most common cause of spherocytes is going to be autoimmune hemolytic anemia. If it is not autoimmune hemolytic anemia, then you will think of hereditary spherocytosis, and if it is not hereditary spherocytosis, you will think of G6PD deficiency anemia. But over here, the first thing I will think of is autoimmune hemolytic anemia. Further, they have given me another picture over here, because whenever I'm dealing with a hemolytic anemia, blood is breaking, I would expect that if the blood is breaking, then the bone marrow should be doing more work, and that the bone marrow has. Can you see there is a sudden increase in these cells? What are these? These are known as reticulocytes. Why are they looking a little different? Because reticulocytes are using a stain. They are stained with the help of supravital stain. Do we know an example of supravital stain? That is going to be new methylene blue. That's why the blue color is coming over here in reticulocyte. And one last question from him at, what are these blue color dot dot dot? What is reticulocyte made up of? It is made up of reticulum of RNA. So actually that is what is being stained over here. And obviously if the blood is being broken, then the reticulocyte production in the bone marrow will increase, and all of that is making sense over here. Now they've asked you which of the following infection would you link with this clinical scenario above. So if I'm thinking of autoimmune hemolytic anemia, I'm sure all of you have read about two types in pathology. One is warm autoimmune hemolytic anemia, warm being because it is due to which antibody? IgG, and IgG works at a warm temperature, that is 37 degree. We've always learned IgG is garam. So warm autoimmune hemolytic anemia at 37 degree, and this is associated with a leukemia, that is CLL. I don't see any feature of a blood cancer or leukemia here. So I will think of the other situation. Maybe this is a case of cold autoimmune hemolytic anemia, because there are many types, but making it very brief, this is because of IgM antibody, and it occurs at a cold temperature of 4 degrees centigrade. And in fact, the most common infection that is associated with this is going to be Mycoplasma. So now when I put 2 and 2 together, I can see that, oh, this is a case of Mycoplasma, which has resulted in autoimmune hemolytic anemia. Because the blood is breaking, that is why the reticulocyte count has gone up, and that's how integration of path and micro has been done. Now, when I move forward and you're talking about Mycoplasma, I hope you remember it shows you the classical fried egg colonies. And can you see these fried eggs are so small that you will have to actually put a stain on them. So the stain used for Mycoplasma is the dyeing stain. And now you'll know how I've integrated images with every question. So the fried egg colony of Mycoplasma, which is seen on dyeing stain, has been put up here. A few days back, I gave you a homework that dyeing stain is used for Mycoplasma pneumoniae. And I had asked you a question that Dyne's phenomenon is used or is seen in which particular organism, and all of you in the comments had given me a perfect answer that Dyne's phenomenon is for Proteus. And in case you feel I'm not reading out on the answers, you're highly mistaken, because I'm regularly following each and every answer and comment and correcting you also in case you're given a wrong answer in the comments. So please keep the questions and the comments flowing up there. Okay, now moving on to the next question, which is question 3. It's heavily today only microbiology, because I know that's where you're struggling. Now we have, forget this entire question. I can see some buzzword which is very evident, something to do with United States of America, and over here I see that there is a rash which is different. It is looking like a bullseye, as well as whenever I see a bullseye kind of a rash, I know I'm talking about Borrelia burgdorferi, because the disease that we have in USA is going to be Lyme's disease, which shows this kind of a bullseye rash, and that is caused by Borrelia burgdorferi. Let me give you another full view of this. Borrelia burgdorferi is the name of the bacteria. The disease that it is causing is going to be the Lyme's disease, which is very commonly seen in USA. And how does this occur? This occurs by the bite of a exuded tick or a hard tick. So where the tick will bite, that is where the redness will start. Can I say this red infection is known as erythema? Okay, so the red color rash is erythema, but then I noticed this red color rash is spreading outside. It is trying to make a ring like annular rash or a bullseye or a target rash. So is it spreading outside? Yes, it is. Can I call it migrans because it is spreading and it is going on for a very long time? That is why I can call it chronicum. So this rash is together known as ECM, erythema chronicum migrans, and the appearance is the target, bullseye or annular. It is caused by Borrelia burgdorferi. Now I can read the question about a 25-year-old college student. There are few symptoms that he noticed after returning from a hike in New York. Originally, there was an expanding rash. Can you see? Chronicum migrans, it is expanding. There are, of course, flu-like symptoms also, and these are resolving spontaneously. Started having symptoms of dizziness, syncope, dyspnea, chest pain, and palpitations, which tells me that can this rash further complicate into cardiovascular and central nervous system? Yes, multi-organ involvement can occur. Everything is going in favor. Also, I want to look at the other Borrelias that are given over here. When I look at Borrelia vincenti, the name only tells me that this is going to cause Vincent's angina, which is very obvious. When I look at the other two, that is Borrelia dattoni and Borrelia recurrentis, both of them are going to cause a disease called relapsing fever. I mean, it's obvious that relapsing fever means the fever is coming and going. What's the difference? Number one, the name of the bacteria is different and their vector is also different. Borrelia dattoni has a T, so this is transmitted by the tick, and Borrelia recurrentis is going to be transmitted by the louse. All the Borrelias are done. I think we are ready to move on to question 4, a simpler one. What is the stain used for staining fungal elements? Is it acid fast, gram stain, methenamine silver, or all of the above? The single best answer will be methenamine silver. Whenever we have a silver stain, the color that we get is always going to be black. So let me have a look at all the stains of fungus, and this was a very recent question asked in the INI-CT exam also, so it can be asked in NEET and FMG as well. Now the first stain that I see, black color, all of these are seen as black color fungal hyphae. So this is referred to as the Gomori methenamine silver stain, and hence we've got the blackish hyphae over here. The next one, where you get pink color hyphae, P for pass, P for pink, everyone knows. The third one, I can see a fluorescent microscope. As soon as I'm using a fluorescent microscope for fungus, the stain that is coming to my mind is calcoflower white, which has something in its name. Calcoflower white will tell me that I'm going to use the fluorescent microscope for the visualization of this. Finally, coming to the culture media for fungal organism is the Bowrough's dextrose agar. There's a PYQ on SDA that it has a pH of 5.6 or roughly between that range. So you've got some whitish growth of some, let's say this is a candida or some kind of fungal infection, and that has shown this whitish growth. Now what I'll do, I'll pick up the growth from here and I will take this growth and look at it under the microscope. Can I say in other words that I took a culture and I am now trying to see the morphology of the culture, and for seeing the morphology of the culture I have used a blue color stain known as LPCB, lactophenol cotton blue. So if they ask you which of the following stains is used for culture morphology, the options will be silver stain, pass stain, calcoflower white and lactophenol cotton blue, all of them are for fungus. But what is for culture morphology? That is lactophenol cotton blue. Going back, Gomori methenamine silver stain was the black color stain, best stain for fungal elements. Moving on to question number 5, another image and a clinical question combined. As I said, today is the microbiome. The farmer presents with a warty cutaneous growth on the foot. Histopathology shows classical, I don't think anyone's getting this wrong, the copper penny body. So this has to be a case of Chromoblastomycosis. It might sound as a very simple question, yet it is a topic that is coming every year. So you have to know everything about it. They said there is a warty cutaneous growth in a farmer. So that means that this is the disease which is always going to be seen in farmers because they tend to walk barefoot. So when they walk barefoot, because of trauma, the fungus is going to enter into their foot. And can you see that warty lesion that they mentioned? Because of these cauliflower-like warts, this chromoblastomycosis is also known as verrucous dermatitis. Now when we do a biopsy and we look at it under the microscope, I mean, it's very, very obvious. You can see the classical copper penny bodies, and no one on this planet is going to give you the word copper penny bodies. They will give you the other names of copper penny bodies, that is MMS. So please note, copper penny bodies are known as the medullary bodies, the muriform bodies, and the sclerotic bodies. These are the 3 names that will be given. Now, all in all, chromoblastomycosis is the name of the disease, not the name of the fungus. And this is a previous year FMG and NEET PG question, that what is the name of this fungus over here, and that's really tough to remember. It is caused by Fonsesia. There are multiple species, Fonsesia pedrosi, Fonsesia compacta. So just learn Fonsesia, and anything written ahead of it can cause chromoblastomycosis. Exophylla, Phylophora, Cladophylophora. So I realized that this is how we had learned all the chromoblastomycosis are caused by the FFF organisms. Also, F will remind me that a farmer is walking barefoot, and this will also remind me that the lesions, not always but are very commonly seen in feet. So farmer, feet, and all the FF organisms, Fonsesia, Exophylla, Phylophora, Cladophylophora, all of these come under chromoblastomycosis. Question 5 is done. Moving on to question 6, a classical one-liner. It's also an image-based question. Which organism cannot be grown on an artificial culture media? Means that, let's assume I'm talking about Staphylococcus aureus. This can be grown on blood agar. This can be grown on, remember, samosa, Staph aureus is grown on mannitol salt agar. So this can be grown. Talking about MTB, how can you forget the Lowenstein-Jensen media? Talking about Streptococcus pneumoniae, again, all of these can be grown on blood agar. They show hemolysis. What cannot be grown is Mycobacterium leprae, because for Mycobacterium leprae, we will have to grow it in an animal. Since it doesn't grow on an artificial culture media, we'll have to do animal inoculation. And the animal, if you look carefully, has these 9 bands. So that is going to be the 9-banded armadillo. In case 9-banded armadillo is not mentioned in the question, then you will be using the foot pad of mice, which is very commonly used in India. You will inject these animals and you will grow Mycobacterium leprae. So this was another spotter, and the next question done. Moving on to the next question for all of you, that is question 7. A child who seems to be having the time of his life. That's how the image is. There's a 3-year-old male child was brought to your clinic with an erythematous rash on the cheek, which later spread downwards to involve the trunk and the limbs. He also had low-grade fever, headache, and a mild upper respiratory tract infection. The suspected organism contains a single-stranded DNA. Well, DNA viruses are always double-stranded. The only single-stranded DNA virus that we know of is the Parvovirus B19. I hope you remember the story of Paro and Devdas. Paro is left single in the end. So Paro is the only virus which is going to be single-stranded DNA. Rest all DNA viruses are double-stranded. So now when I know Parvovirus and I know that, okay, there's a red rash on the cheeks, am I talking about the slabbed cheek appearance? Slabbed cheek appearance is known as erythema infectiosum. Let me show you a better picture. So when I say erythema infectiosum, this is referred to as the slabbed cheek appearance that you can very well see over here. And along with that, this is also going to spread on the hands and on the feet. So you are, apart from this, also going to see something known as gloves and socks syndrome. Reason being, the gloves and socks are hands and feet rash that you see in these patients. Technical name of this is erythema infectiosum. I hope you did not confuse this with hand, foot, mouth disease. What is the difference? Hand, foot. See, hand is involved here also, foot is involved here also. But in hand, foot, mouth disease, it is the mouth that will show you. Around the lips, the mouth will show you the lesions. Here, the slabbed cheek or the cheeks are showing you the rash. This is not hand, foot, mouth disease. Hand, foot, mouth disease is caused by a virus which is known as the Coxsackie A and B viruses. A more commonly. That's different. So remember, while the hand and the feet will be common to both, if you get a slab cheek appearance, it's parvovirus, and if you get a mouth lesion, then it's hand foot mouth disease. Forget all these rashes. What does it cause in the bone marrow? It tells the bone marrow to stop working. Strike of the bone marrow. Either only the red blood cells will stop working, that is pure red cell aplasia, or the entire bone marrow will stop working. No RBC, no WBC, no platelet. The bone marrow has a shutter down. That is aplastic crisis, a very famous question. Usually this aplastic crisis is seen in hemolytic anemia. So listen to the question. There will be a patient who will have some hemolytic anemia, either a hereditary spherocytosis or a sickle cell anemia. These are their two favorites. And they will say in that person, there is suddenly a complete shutdown of the bone marrow, that is aplastic crisis, which is the virus or organism that has caused it. That is Parvovirus B19. I hope this question is also done. A classical appearance, Parvovirus B19 and erythema infectiosum. Coming to question 8 over here, oral hairy leukoplakia is associated with which of the following? And the answer is classical, that is Epstein Barr virus, EBV. There are classical, again, what can be the image based question that will come for Epstein Barr virus? Let's see that. We know Epstein Barr virus commonly causes infectious mononucleosis. I have already taught you this in the previous lectures, that this is also known as kissing disease. Reason is that it spreads by very close contact. Another name for this is also going to be glandular fever. I mean, the fever component everyone knows. Glandular means glands of the body will be enlarged, like the salivary glands will be enlarged, the lymph nodes will be enlarged. So these are the other names. That is one disease. Apart from that, it can cause a lot of malignancies. Malignancies are of two types. Either it can cause carcinomas or it can cause lymphomas, and we are going to quickly revise through them. And you might be wondering, ma'am is teaching everything and not giving homeworks today? Because I will. On the last question, you will get a homework. The most common carcinoma that you have with Epstein Barr virus is going to be the gastric carcinoma. That's a very famous PYQ of FMG exam. The second most common carcinoma that you have is nasopharyngeal carcinoma. When we talk about lymphoma, Hodgkin lymphoma can also occur, non-Hodgkin lymphoma can also occur. In non-Hodgkin lymphomas, they love to give the history of Burkitt's lymphoma with EBV. Now, what's the image-based question that you'll get over here is this cell on a peripheral smear, you'll see a cell which has a classical appearance known as the ballerina skirt appearance, because look at the cytoplasm, it's looking exactly like a ballet skirt. So this ballerina skirt appearance cell is known as the downy cell, and that's the image-based question that you get with EBV. Well, coming back to the question, I have seen the main infection, I have seen the cancers, but don't forget there are some miscellaneous things also that EBV can cause, one of which is oral hairy leukoplakia, and that is exactly what was asked in this question. Please, when you go in the exam, oral hairy leukoplakia is a totally different entity, whereas in pathology we study something called hairy cell leukemia, and I don't know why under that stress you end up messing these two up. Oral hairy leukoplakia, totally different etiology, EBV. Hairy cell leukemia is a kind of a leukemia lymphoma, a white blood cell cancer over here, and that is associated with a mutation which is known as the BRAF V600E mutation. It is a bone marrow defect, so don't mess up on these two, although they sound very similar. Moving on to question 9, where you're going to get all of your homework for the day. There is an adolescent, and I don't think you're reading this because sometimes this entire session is to emphasize that images are so important. You've got a pseudomembrane over here, and along with that they have mentioned fever and lymphadenopathy. You know this is a case of diphtheria. They've asked you what is the mechanism of action of diphtheria toxin, and all of you are going to write what? So there is going to be toxin acts by ADP phosphorylation, although I've read that it very commonly acts by ADP ribosylation of EF2, but over here ribosylation was not mentioned, phosphorylation was mentioned. So either ways, that's the best answer that I'm going to have. It is not going to work by cyclic AMP or GMP. It is not going to work by inhibiting 60S ribosomes. And this was also a homework which many of you told me a few days back in the 10 on 10 series, which I will quickly revise for you. What are the toxins that are going to increase cyclic AMP? We have learned it by the mnemonic cyclic AMP, which tells me number 1 is cholera toxin, second is going to be anthrax toxin, then for M we switched it into E, and that is going to be the E. coli toxin, which is going to be the labile toxin, and finally we have the whooping cough, that is pertussis toxin, which increases cyclic AMP. Then if you ask me which are the ones that increase cyclic GMP, that is the E. coli toxin, which is going to be which one? The stable toxin. How did we learn this? We had always studied a thing that gives you a life lesson, that labile people will always be in the air. People who have are just boasting about things without any any ground reality, they will always be floating in the air. So please remember, labile toxin, air, that means cyclic AMP. Whereas someone who's very stable in his thought process and life will always be very grounded. So stable is on the ground, which tells me that stable toxin is going to be ground, that is cyclic GMP. That's the basic that I can teach you. Now coming to what is the diphtheria toxin. So diphtheria toxin acts by decreasing protein synthesis, that is DPS, which are all the toxins that decrease protein synthesis. DPS, that is how we learn it. The D and P is going to be the diphtheria toxin and the Pseudomonas toxin, whereas the S and S is going to be the Shiga toxin and the Shiga-like toxin. I mean, Shiga toxin is obvious, it will be released by Shigella, whereas the Shiga-like toxin is released by E. coli. So please note that decreasing protein synthesis is done by diphtheria toxin, Pseudomonas, and Shiga-like toxins. But how do they decrease the protein synthesis? Divided into first two and last two. So diphtheria and Pseudomonas will cause ADP ribosylation of EF2. That is how they are going to go and decrease the protein synthesis. Whereas the two Shiga, they are going to inhibit the 60S ribosomes, and that is how they will go and inhibit the protein synthesis. So this is what they asked you for diphtheria. But how did you make this as a case of diphtheria? Because what did you see over here? We saw a pseudomembrane. So there are 2-3 images for diphtheria that they ask you. Number one, in the patient, you are going to see a membrane that is present in the mouth, that is going to be a pseudomembrane. Secondly, the lymph nodes on the neck will be very, very enlarged. So you will call this a case of bull's neck. When you see these two classical findings, you know you're dealing with diphtheria. Diphtheria on microscopic examination has granules known as volutin granules. Lots of names given. If you look carefully, these are these bulbous granules that we have over here. Some people call it volutin. Then there's another fancy name given to it, that is the Babes-Ernst granules. Then I noticed that these granules are present on the poles of the bacteria. So if this is the bacteria, the granules are going to be present on the two poles. So these are also referred to as bipolar granules, and these are also known as metachromatic granules. So many names for the same thing. What does it have? It is going to have polymetaphosphate. What is the meaning of this? See, what is your energy known as? ATP, human being energy, ATP. What is the full form of ATP? Adenosine triphosphate. So this is a kind of polymetaphosphate, another phosphate in the bacteria, which is going to act like an energy source in this bacteria, and it is stored inside these granules. Okay, these granules that I am seeing over here, the staining that I've used is the Albert stain. And now starts the 3 questions or the homeworks that we have for the day. Homework number 1, which I've also enlisted in the end, and there's one more question before you end the session. Number 1, you will tell me, other than Albert stain, you will tell me all the stains of volutin granule. Second and third homework also to do with diphtheria. You will tell me which is the test of diphtheria for knowing about the diphtheria toxin or toxigenicity, and which is the test of diphtheria for knowing the susceptibility, that whether you are susceptible or immune. These are the 3 homeworks. But before I go on to that, I hope we have solved this question, which brings us to the last question for the day, which is a true spotter. So much so that I didn't even want to give you the site or the history, because when you see these 4 pictures together, you know it's a thyroid swelling, and you know you are dealing with papillary carcinoma thyroid. Why? Because the first finding is the Orphanani nucleus. Orphanani nucleus means the nucleus is completely white. So they don't write Orphanani, they are going to write optically clear nucleus. See, they know your fancy names are good. They want you to know the meaning of it. So optically clear nucleus is the same as Orphanani. The next finding that I see over here is inside the nucleus, I can see an inclusion. I hope all of you can point out that inclusion, that is intranuclear inclusion, which is another finding of papillary carcinoma. The same intranuclear inclusion you can see over here. This is the nucleus and there is an inclusion inside it. That's an intranuclear inclusion. One more thing I can see over here, the nucleus has a line going through it. I'll draw it and erase it. There is a nucleus having a line going through it. I'll draw it and erase it so that you can see it. This is known as the intranuclear groove, and this is exactly what gives the nucleus a classical coffee bean kind of appearance. Finally, which bodies are seen? No one can forget those calcium bodies of papillary carcinoma. Those are the Samoma bodies. So Orphanani, inclusion, groove, Samoma bodies. That's okay. But the question over here is, what is the mutation, the most common one that you see in papillary carcinoma? It is the BRAF V600E mutation, which is asked multiple times as a PYQ, and you have to know this. With that, we wrap up the 10 questions questions of the day. The 3 homeworks are written in front of you. I'll be waiting for the comments. And now I'll be meeting you in the next session. That would be day 8. And we are nearing the end of this series, but don't worry, we're not going to stop. We will have something new, better and exciting after the 10 days are done. But I hope you're also following the one-liner sessions that I'm taking on the Prep Ladder channel. One-liner for pathology is already done, so you can view that, and the PDF is on Telegram. One-liner for microbiology will be conducted on June 5th at 5 p.m. and after that there'll be 100 one-liners. I will be sharing the PDF on Telegram again. So in case you want to join in, you can join in live as well. So I'll be meeting you in this series now on day 8. Study well. All the very best.